Hello, everyone. Welcome back to the Vocal Pelvic Floor. Today, I'm joined by Dr. Shanti Mohling, an exceptional surgeon and one of the few women leading in advanced gynecologic and endometriosis surgery. In a field that can still be dominated by male voices, Dr. Mohling brings not only surgical excellence, but a patient-centered approach that's transforming care for complex pelvic pain and endometriosis. In this episode, we're talking about nerve-sparing techniques and the gut endometriosis connection, and why her work is changing the conversation around what true healing and restoration looks like in endo. Let's dive in. Hello, everyone, and welcome back. I'm super excited for a bunch of reasons that I will be sharing shortly to have Dr. Shanti Mohling here with us. Welcome, Dr. Molling.
Thank you so much. It's an honor to be here, Ginger.
Yeah, I have just been really excited to welcome you to the podcast since I saw you were on the agenda at Endo Summit last year for talking about the gut microbiome, which is one of my favorite topics. So y'all are in for a real treat. I want to brag a little bit and do a bit of a bio before we kick everything off. So let me do that first. Here we go. Dr. Shanti Mohling is a board-certified, fellowship-trained gynecologist and gynecologic surgeon. She joined Northwest Endo in May of 2021 and brings her outstanding talents in endometriosis care, gynecologic surgery, and biomechanics to the practice. Dr. Mohling is committed to, of course, providing world-class surgical care to women with complex surgical issues, including endo, and also chronic pelvic pain because they overlap so much, as well as heavy bleeding, fibroids, pelvic organ prolapse, and incontinence, what we call in pelvic PT all the things. Dr. Mohling focuses on minimally invasive surgical techniques for all surgeries, which is incredibly important, and we'll probably touch on that a bit. She has great experience and knowledge in the biomechanical aspect of pelvic pain and dysfunction, which is a very unique part of who she is and what she does. So you have to listen to the entire thing, because you may not know that she's a former massage therapist in pre-med years, and that gives her such a interesting, unique, deep appreciation for the role that the musculoskeletal system plays in perpetual pelvic pain, which is in pelvic PT, that's our jam. You might guess she's a very in-demand speaker and educator on this topic. And so what I want to focus on is you're speaking all over the place. You just got back from India, speaking over there. You're doing so many different things. So the two topics that I'm just going to kick things off with, and we'll kind of break them down from here, is nerve-sparing surgery and why that's so important, and also why the gut microbiome is so important and previously, historically, just overlooked, kind of as endo was and has been as a disease as a whole. So welcome.
Thank you. Thank you so much.
Yeah. All right, right out of the gate, I don't know that most listeners will appreciate, now they're going to have heard and listened to. So listeners, if you have not listened to the previous surgical podcasts talking about why ablation is not a solution for surgery, that excision surgery is the gold standard, please go back and listen to that, because this is like an intermediate to advanced topic discussion here, what we're about to dig into. So I think that our listener may not be able to, or may want more information on what nerve-sparing surgery is for endo. What does it entail? How does it differ from traditional excision surgery?
So I think partly it's important to realize that it's kind of in vogue now to say you do nerve sparing surgery. And I think even before I learned what that was, I was instinctively doing that because clearly you don't want to be cutting important nerves, whether they're motor
Mm-hmm.
nerves or sensory nerves, and particularly in the pelvis. These nerves that all of this endometriosis and inflammation are adjacent to, those nerves control our bowel function. They control our bladder function, holding our bladder, releasing our bladder, feeling the urge to use our bladder. They also control our sexual function and being able to lubricate, for example. So, um, nerve sparing surgery can include everything from minor disease, like early stage 1 or 2 disease, where you're removing peritoneum and lateralizing the nerves, separating the nerves from the diseased tissue that you're removing as much as possible. It can also be involved when you are doing a hysterectomy, for example. I've seen patients over the years who say, I have, since my surgery, I just don't lubricate as well. Well, that was probably because that inferior hypogastric branch to the vagina got cut at the time of hysterectomy. Super easy to do if you're not thinking about it. I'm sure I've done it myself, especially in the past when I didn't have the luxury of such incredible visualization that today's laparoscopic equipment affords us. So nerve sparing, I think really this concept got coined and maybe initiated by Marcello Ceccaroni, a surgeon in Verona, who really has spearheaded the concept of nerve sparing surgery for the bowel and really understanding that pelvic anatomy so well that as you're excising bowel disease, you are lateralizing or separating the nerve tissue from the bowel so as not to injure it. There's some aspects where some nerves are going to get injured no matter what, and sometimes they are already injured by the disease
True.
state itself.
Yeah.
So, what we're trying to do then is get the disease off. Can you save some of the nerve? Is it going to regenerate? And nerve regeneration is very slow. It takes a year or two to
Yeah.
really regenerate. Full bowel function, for example, after a complete low anterior resection of the bowel. Even
Well,
if you're doing nerve sparing techniques, you're
right.
not going to fully recover for a year or so. So is that a start to answering your
Yeah,
question?
it definitely is because, from the full spectrum, if we step back and take the 40,000 foot view in, um, which is, I think, what patients often want to hear. They want to hear if they've been through the surgery and they don't have full function yet, and they walk into my office, for example, or any pelvic PT that specializes in
Right.
endo. They're like, two hands in the air, what's going on? How long can I expect this to happen? When will it get better? And so that's a really important point that you made, that it could be 1 to 2 years. But the good thing is,
It has a
it's
good
good and
chance of
bad.
recovering. Yeah,
Yeah, exactly.
exactly.
The bad news is it's 1 to 2 years. The good news is it's 1 to 2 years. You have time. You have time to heal and recover and regain full function.
Yeah,
And so I think that's overarchingly a good sign. Even though patients will be initially frustrated when they come in, I'm like, no, 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 we have time.
yeah,
Yeah.
yeah, absolutely.
What do you see as the nerves that are most commonly impacted in deep infiltrating endo? And just give me an example. I know you have multiple cases to pull from of how you approach protecting those during surgery when you come upon that where, the lesions are just everywhere.
Yeah. So what's interesting is that I think sometimes you've got direct impact on the nerve, right? Or so I don't yet, although I am training to do the full neuropelviology work, but you can have nerves like the sciatic nerve with endo directly on that nerve, right? And it's a big enough nerve that you can kind of cut the disease off of it, right?
Mm-hmm.
Some of our nerves are branches that are smaller, and some of those will get injured. And maybe to some degree, when you're removing endometriosis and you've got these little fibers, maybe that's part of why pain gets better, because you actually cut some of those sensory nerves that were attached to endometriosis. Um,
Mm-hmm.
so I would say that the most commonly directly affected nerves are going to be the inferior hypogastric nerves, right? With branches to the bowel, to the vagina, to the uterus, to the bladder. And so as I am working my way down from the pelvic brim down deep into the pelvis and excising disease or doing peritonectomy, my technique really is to get into the retroperitoneum and begin to get that peritoneum gently separated from not only the nerves but the ureter, the all of the vessels that lie and live in that retroperitoneal area, but the nerves included. So I think part of the technique that's so effective is not just to cut the tissue off, but as I'm removing that peritoneal disease, I'm bluntly lateralizing, gently pushing the nerves away from the tissue I'm going to remove, right?
Mm-hmm.
And then sometimes it's really stuck, and you do need to use a little, maybe some cold cutting, and sometimes even a little bit of monopolar energy to separate that tissue from dense fibrosis. And I don't think I've had to fully cut through like the larger branches of the inferior hypogastric very many times, but there are a few times where there's just so much fibrosis, the disease is already so infiltrated the nerve that that dysfunction already occurs. And fortunately, we have two sides, right? So if the bladder still gets information from the left side and the right side is boxed because of fibrotic disease, you might give it chance actually to then heal if you can get enough of that fibrosis off.
Yeah.
The other thing that's interesting is sometimes I'll do a superficial layer of the endo removed, and I'll send a second layer that'll still have endometriosis on pathology. And sometimes the deeper layer, say I'm on the bowel, say I'm on the sidewall or uterosacral, is just fibrosis and not endo. So usually I'm a fan of removing most of the fibrosis too. But when I do see, say on the rectum, some fibrotic tissues that the pathologist says there is no endo here, I think, okay, sometimes if you get all the endo and you leave a little bit of fibrosis on a nerve, it may be able to heal now that you've taken this big inflammatory
True.
amount of
Yeah.
tissue out of the picture, right?
Yeah.
So when you're talking about nerve function, it's a real balance and art as a surgeon. Like, what am I leaving behind and why, right?
Mm-hmm. That's
And
such
it is.
a brilliant, nuanced way to describe it. So let's take that inferior hypogastric nerve just a little bit further. What kinds of outcomes and symptom improvements? Because I think that's probably the question on most listeners' minds are, what would I feel if that was happening
Yeah.
to that particular nerve?
So it might
How
be
have,
harder to pee,
yeah.
right? You're like sitting there. You might have to strain to pee, right? It might be chronic constipation. It might be vaginal dryness. And if you really really destroyed both inferior hypogastrics, you might not be able to pee at all. So
Yeah.
some really radical cancer surgeries. Um, I don't think I've ever had a patient with that inability to void after surgery
Yeah.
long term.
It's and when so the kind of the fallout from time of them having to strain or feel constipated, etc., then turns into the whole musculoskeletal issue that you can certainly appreciate with your very diverse background of then there being pelvic floor dysfunction or pulling in obturator internus dysfunction or other things that then they could mistake for, and I've had this happen so many times in patients, a hip labral tear. So it looks like hip pain. It looks like a hip cartilage issue. Or it looks like lower abdominal quadrant pain when in fact it was a psoas issue or a pelvic floor problem.
Absolutely. Yes. Thank you, doctor. Absolutely.
Yeah.
So often overlooked, right? Yeah.
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 Yeah. And so
And
that,
I think about someone with just massive endometriosis or even stage 1 or 2 endometriosis, but debilitating pain. They're keeping that gate closed down below.
oh,
They are clamped
definitely.
down. They are not letting in through the vagina. Everything is clamped down. And sometimes we're really post-surgery, some patients we have to really work with physical therapy to unwind that.
Yeah. That's a super important point, because patients will come in, and I think they often think, which is, it's not to blame anyone at all. It's just that, you know, you as a surgeon you have such this heavy burden of clearing someone with, endo and helping them. And then we have our own set of, issues and burdens in PT. And so no one really tells the patient, hey, just because you had excision surgery doesn't mean your musculoskeletal issues will magically resolve post-op.
Absolutely.
Your psoas didn't get a memo. Like,
No. And we forget that patients often are so deconditioned by the time they come in the
yeah,
door that
yeah,
if they're coming in with a cane, they're probably going to leave surgery with a cane too
yeah,
initially.
yeah.
Although that being said, I just saw this absolutely adorable patient for post-op. Like she came in 10 weeks post-op. We really wanted to check back in with her. When I first saw her, she was so like constricted and really like couldn't move well and in so much pain, super slender, beautiful young woman. She felt this tethering in her body and went to so many providers who just really thought she needed to get physical therapy only and or stretch
Mm-hmm.
more, yoga more, whatever.
Mm-hmm.
So she had literally a loop of transverse colon and rectosigmoid colon tethered together right at the place where she had pain, right? So now that was also involving the abdominal wall. So she had an abdominal wall endo along with the bowel endo removed, abdominal wall endo removed. She comes in today, 10 weeks later, and she's just oh my God, you're a different person. Like she can move,
Yeah,
right? And
yeah,
and so I do think that there are times when just surgically removing something frees someone up enough that they can move.
definitely.
But sometimes if it's set in too long, then you definitely are
Yeah.
unwinding the clock a long way.
I think that, and I can chime in on my own experience, because I had bowel endo, and then I had the bowel tethered to the sidewall and kinked on itself.
Oh, so this is very familiar to you.
Yes.
Yeah.
And so there, for me, I was one of those people too, where I'm like, oh my, I can stand, I can digest food for the first time.
Wow.
I don't have to randomly take a knee on a sidewalk walking the dog
Yeah.
because of
Yeah.
digestion being absolutely hindered.
Wow. Yeah.
So it was profound,
Yes.
very profound. It was night and day. And then you will have and that's where, we try to distinguish between what should be post-op relief, right? And what is a deeply ingrained motor pattern. I had the benefit as a PT of already knowing what the motor patterns and timing should be on what muscles should fire when. So I had fixed all that before. So I didn't have the post-op pain still the same. I had post-op, okay, no pain, like zero pain. Everything's great, right? So I think that to encourage, the listener too, that if you are having some lingering pain post-op, it could simply be timing and motor patterning, a muscle that just needs to have the reset button pushed,
Yeah.
to,
And
yeah,
again, also that bringing back full circle that nerves are the slowest to grow and
yeah,
repair. And it can take a year. And it's funny, I was an expert witness in a case of a sciatic nerve injury and that was probably from positioning. And I was flying to give testimony. And oddly enough, the person sitting next to me was a nerve researcher. And he starts talking to me about how nerves are so slow to grow and that even the sciatic nerve can repair, but it slowly, very, very slowly heals. It can take a year or two. And it's like, thank you for that information.
yeah,
It's just what I needed
totally.
to hear.
Yeah,
Yeah. So,
there's hope. There's hope.
yeah, right.
Patience and hope.
Totally. Yeah.
It's a mix of patience and hope. So, what do you think some of the biggest challenges are, like in teaching or spreading awareness about nerve sparing techniques among surgeons?
Well, I mean, in some ways, I think the bigger challenge is teaching them to do excision,
True.
getting them to
True.
recognize that it
Number
helps.
one, excision, not
I
ablation.
think it's so much about technique. It's so much about technique and understanding anatomy, and really being aware that you also need to take the tissue off those areas, right? So I think anatomical awareness for sure, number one. But I was reviewing a video recently, and they did a great low anterior resection of the colon, but they left all this sidewall disease overlying the epigastrics. And so,
Oh,
like, okay, they have the ability to deal with a nodule, but don't have the awareness that that sidewall disease is contributing to the problem, and that that person is going to have residual pain, undoubtedly, right? So I think that all of these conferences and seminars, and when I teach for intuitive, I try to emphasize this, that you can very safely be near the nerve, and that it just takes more time. You're not going to do a 30-minute surgery. You're going to be tediously moving this disease off, and at least getting all the endo. If you maybe leave a little fibrosis on a nerve, that may be in the best interest of the patient long term.
yeah.
But that
You kind of
takes
answered
one's
my next
time, and just
question.
being so very, very delicate to get that disease off. Yeah.
I think you're reading my mind because I had a question related to this, and you just like went right into it
Tell
and
me.
answered it. It was a question related to, you know, when endo is infiltrates a nerve, like direct, like the pudendal nerve, or something like that. Is it possible? Is removal possible, or what happens at that point? You mentioned maybe leaving some fibrosis in order to, um, you know, kind of balance out taking the endo, but maybe not taking the fibrosis. Can you describe like that decision making process?
Yeah, I think it's the same as, it's really similar to removing extrinsic disease from a ureter, right?
Okay.
And so if the structure itself is healthy and you are comfortable removing the disease and getting up close and personal with the structure, and also have the techniques to spread, to cut carefully, you can remove this disease from anything, right? Like, it's terrifying the first time that you take it off the peritoneum diaphragm over the heart, and you're just like, oh my God. But
Yeah.
you can do it, right? You just have to go slowly and take your time, and remember that things have nerves and are going to jump. And so, yeah, particularly if you use energy near a nerve, it's going to jump and you have a greater risk of injuring it, right? So, um, sometimes you're using less energy and you're very carefully cutting disease off, right?
Yeah. So, what should patients like? What's the takeaway message before we shift into our next topic? What's the takeaway message? I think we've touched on it a little bit. Like, patience is one. Keep the hope because it could be 2 years, but also be patient because it could take 2 years. Um, are there risks? You know, what do you kind of take patients through when considering that, you know, a nerve is involved? Like, I've had patients come in clearly like the sciatic nerve is involved. They're getting pain. It's going past the knee. It's going into the foot. They're having regular things happen. So when you have that presentation of someone coming in and they clearly have nerve related pain, how do you walk them through that in terms of preparing them for what comes and what kind of therapies they may do
Okay, so
after?
that's a really good topic to bring up. So I really believe that when there's sciatic pain, it's not necessarily endo on the nerve. That when you have motor dysfunction, you probably have endo on the nerve. And then if you have that radiating pain, it's usually nearby endo that is creating a referred pain. And that you can remove the endo really more safely. But when you have true motor dysfunction, like a foot drop or
Yeah.
leg drag, then you really need one of very few specialists. to remove that
That's a
disease.
very good point. Yeah.
So often I will remove uterosacral disease or deep peritoneal pocket disease, and the back pain gets better,
Hmm.
right? Even though I haven't been really directly on the nerve, that referral, deep referred pain is creating and mimicking some of the same um, patterns as a pinched sciatic nerve, for example, right?
Yeah.
But I think when the disease is really on the nerve, you're going to have, like on a pudendal or on the sciatic nerve, you're going to have more, um, well, particularly with the sciatic, you're going to have motor dysfunction.
Yeah. And so for the listener, with that motor dysfunction, it would be difficult to walk. It would be
Yeah,
difficult to do your ADLs because your muscles aren't working the way you want them to, versus them you feeling a sensation like hot, cold, numbness, stinging,
exactly.
tingling, that kind of thing, which means it could be near, but it's how you're feeling instead of the foot literally dropping and you not being able to walk the way you want. And so when it's the latter, um, and there isn't that motor involvement, then yeah, if you are in the Pacific Northwest, okay, listeners, you know who to go see for that, because that is an urgent issue. You can't just let that go,
Yeah,
right? Yeah,
exactly.
yeah.
Exactly.
Okay, so here is a topic that I have been very just super curious. To say super curious is not even the right phrase. It really isn't. It's like a little obsessed, maybe a more accurate phrase. When you're talking about the gut microbiome, the first research that I heard and read about was back in the early 2000s, like it's like 2010 or so, about the gut microbiome and the implications for C. difficile in infants when they're like, breastfeeding, or vaginal birth versus C-section, and just the colonization of the gut microbiome and how mode of birth and how much, meat you ate that may have, hormones in it, or otherwise could skew the positive bacteria or the good bacteria that you have. So, fast forward in a couple of decades here, and, the gut microbiome is everywhere. Everyone knows something about the gut microbiome in some way, hopefully. But here's, I think, where we'll walk away currently saying the phrase that we love in healthcare and medicine, which is more research is needed. And I think that for this topic, that could not be more true. But can you just brief us, because I loved your lecture last year at Endo Summit on the gut microbiome. Can you just kind of give us the 40,000 foot view, or a little closer in, on the relationship between endometriosis and gut dysbiosis, or microbiome appearances and imbalances, if, so to speak?
Yeah. Let me start with what my research was that I did when I was starting to get interested in this, and then how that led me to thinking more about the relationship between a healthy gut flora and endobelly and well-being, right? So it starts with um, a decade ago learning about celiac disease and learning that there was this molecule, this called zonulin, which holds the tight junctions together in the lining of the small intestine, right? And so when a person who's genetically predisposed, so this is really important, like with endo, we have genetic predisposition, we know this. And with celiac disease, you have a genetic predisposition. And then you've got an environmental component and you've got your gut, right? So the environmental component is what's going in, and this is going to be gluten, right? And then
Mm-hmm.
the the tight junctions start to release, you get an uptick in zonulin, and then between those cells, the cells then are separated enough that anything going through the gut doesn't get screened as well, and you get antigens and negative maybe bacteria into the bloodstream, you get this massive immune response because 80% of our immune system lives on the other side of this gut lining, right? So you get a huge immune response, and then you get full-blown celiac flare disease, right? So the same thing, it turns out, happens with type 1 diabetes. Zonulin goes up, leaky gut, exposure of things, and you get autoimmune mediated disease. Same thing happens with, interestingly, MS or spondylocin. I can't remember what it's called, but other diseases as well.
Yeah. Yeah.
So I wondered, is endo anything like this, right? And
Totally.
so, is there some relationship with endo? And I will honestly say that at this point in time, over a decade ago, when I was thinking about it, I was thinking that maybe retrograde menstruation was a thing. And I don't think it's as much of a thing, but I think it's a little bit of a thing. I think mostly it's embryologic origin. But um, when I wondered, is leaky gut at all related to development of endometriosis symptoms, or is it also related to endobelly and inflammation and the gut difficulties that so many of our patients face? So leaky gut is also called impaired intestinal permeability. And this occurs in a lot of disease states, in fact, not just celiac disease or the ones I mentioned. So I did a small pilot study, and I got a grant from the Endometriosis Foundation, and enough to pay for a bunch of test kits from, I think, North Carolina is where they came from
Oh, wow.
the lab there. And I painstakingly got enough patients to do my pilot study. I did a power analysis, and so it was statistically significant. I had controls who were all negative for intestinal permeability impairment. I had patients with pain and no endo, and they were negative. And half my patients with endometriosis had impaired intestinal permeability.
Hmm.
Now, the thing about leaky gut is that it is it's not a static state, right? So if you have it, you probably have it more often. But
Hmm.
sometimes someone could really be like avoiding their nonsteroidal anti-inflammatories, which, by the way, give us leaky gut. And what do we give all of our kids who have period pain? We give them NSAIDs.
Yep.
It probably also, birth control pills might also play a role. So
Hmm.
someone might be eating really well. They're trying to control their symptoms. They're not taking ibuprofen. They're not on hormone therapy, and their gut's looking better, even though they already have endo.
Yeah.
So they wouldn't show up positive on my test. So I had a hard time recruiting patients because you had to collect your urine for 6 hours, which is the old-fashioned way to really reliably see if someone has impaired permeability. And you drink a sugar solution with mannitol and lactulose should not show up in the urine because it's a large molecule, which is why it works to help someone have bowel movement. And so it if it gets into the blood, it gets into the urine, and that's how you do a urine collection, and you can see if someone has intestinal impaired permeability. So it did show that there was an association. I don't know if it's causal. I don't know if endo causes this or something about endo happens because we have intestinal permeability. We have no idea. But what we do know is that intestinal permeability, when it's impaired, is also related to a dysfunctional or a dysfunctional microbiome, because all this bad stuff can flow in, right, and we can't control it because we have a leaky gut. So um, some of the other things that we know about the microbiome is that a really healthy microbiome keeps our whole functioning of our whole system intact, including our hormonal function. And so there's a beautiful study, and since I'm not having my slides prepared, I can't quote exactly who did this study, but it's looking at ovarian cancer, and patients with ovarian cancer had more dysbiosis and also had certain bacteria that reconjugates estrogen metabolites, making them reabsorbed
Ooh.
elevating estrogen levels
Yeah.
in the body
Yeah.
system, increasing predisposition to breast cancer.
Yeah.
Sorry, breast cancer is what it was, not ovarian cancer.
Yeah.
So so we are learning all these bits and pieces about how the microbiome affects our general function, our hormonal balance, our mood. I mean, it's rather endless, actually. Our digestion, of course, is part of it. I mean,
Yeah.
that's the real tube that we're dealing with. But it definitely has an impact on all the systems of our body. So how do we get a healthy microbiome? Well, one, yes, if we're born by C-section, we're off right at the get-go. We don't have quite as good of luck. If we're not breastfed, we're not getting all those immune globulins and a lot of those natural bacteria from our mothers.
Yeah.
So there's another hit. If we grow up in a very sterile environment where we're not having organic vegetables, which have some nice little microbacteria that are good for us from the farm, then we're not getting all those nutrients that we need. So, what do we do? If we had all those hits at the beginning and then we had plus a ton of antibiotics because we had kidney infections as a baby or whatever we
Mm-hmm.
had, we're behind the eight ball and we need to work to improve, right? So, things that you can do are just generally avoid sugar and processed foods and make sure you're a very wide variety of fruits and vegetables are going to augment and not radiated ones, right? So, probably organic fruits and
Yep.
vegetables. A wide variety will help bolster a microbiome. I'm also recently become a fan of bovine colostrum, and I feel like so here's the reason. So
Yeah.
you mentioned that I went to India and I spoke in India
Yes.
and I went to a travel clinic beforehand and I was given bovine colostrum to take to prevent travelers' diarrhea, which is studied and actually is a known thing that it helps prevent travelers' diarrhea. And I have a history also. I was born in India and then I was there 40 years ago in my 20s and got Shigella and amoebic dysentery. I got terribly sick. And this time around, I did not get sick at all. In fact, I felt
Wow.
fabulous. And I was
Wow.
taking bovine
Yeah.
colostrum before every meal.
So the mechanism is if it's diversifying commensal bacteria or
Yes.
yeah.
Yeah, protective bacteria,
Yeah.
which is what we need. So, and perhaps the immune globulins. So I think that it's really interesting. I wish that if I
That's
were in an
fascinating.
academic institution, I would be like, yes, we need to study this. But
Yeah.
I came home and I started reading about it, and it can heal the gut from overuse of nonsteroidals, and it's used by athletes for muscle recovery. And so I think there is, it's intriguing to me. Can this help with the microbiome? And maybe it can. And it's also really harmless unless you have a true lactose intolerance or allergy to milk, then you probably shouldn't use it.
Yeah.
So,
Oh my gosh. Okay, I have 52 questions. I was
yeah.
trying to add them up in my head as I went along, but
Wait, let me add one more thing.
yeah.
I want to be really clear that fixing your microbiome does not make endo go away.
Yeah. We wish it did, but
It would be wonderful
unfortunately.
if it did.
Yeah.
We could be so happy. But I think even if you had a perfect microbiome growing up, I think if you have all the seeds of embryologic development or misdevelopment, and the deposits left from the diaphragm all the way down, no amount of changing our microbiome later is going to help if you
Yep.
don't get the disease removed. But I
Yep.
do think that a lot of the gut issues that go hand in hand, some of which we may be creating by giving so many NSAIDs and birth control pills to all these kids, might be benefited by really addressing that gut and getting it healthy. It for
Yeah.
sure is going to help some of the symptoms and is going to be important in recovery. So.
Yeah, absolutely. Like, I think I might be a poster child for what you just said because, okay, so I was vaginal birth, breastfed. My mother has endo. Lots of female family members had endo. Never properly treated, unfortunately. That was decades and decades and decades ago. So their treatment was hysterectomy, which we've said a billion times on the podcast is not doesn't it's not a cure for endometriosis. It's not even necessarily a treatment for endometriosis at all. But yeah, I had that good beginning, but with the genetic history. And then I went on into my profession and did what I did and studied Ayurvedic medicine and got a certification in that and studied yoga and all the nervous system regulation that you do. And then I got board certified in lifestyle medicine. So I studied the gut microbiome. And I think in a way it allowed me to, it mitigated it because I was looking at estrogen metabolism. I was looking at the gut microbiome and trying to optimize that. But, it did mitigate the disease process, but never stopped it.
Mm-hmm.
So eventually, I had to have excision, right? In spite of all of those things, it allowed me to live to a certain degree until my body was like, you've done everything you can do. There is nothing else you can do. You have to get excision. And it was very clear at that moment, when I arrived at that moment. But, and of course, other things were found too, like, when your bowel is kinked on itself, well, that'll give you problems on a random day, on a random Tuesday. But yeah, that last point is so important that we want to, manage all of those things. It's certainly from the very yogic integrative medicine, lifestyle medicine side of what I do in pelvic PT, it's paramount because I would not want them to come out of surgery with you, for example, and then just say, whatever you eat is fine. Right. The excision has taken care of it. I'm going to do some internal pelvic floor and needle a quadratus in a, internal, obturator, and then you're on your way. So my questions kind of lie in that, so I'm tracking some of these labs for patients. I'm looking at whether zonulin is an issue, intestinal permeability. I'm looking at their stool tests. So my first question would be, what do you think the ideal follow-up lab to track the gut microbiome is? Because some of us, who are integrative and lifestyle medicine oriented in PT are doing that. And we see really low levels of the commensal positive bacteria. So it's very homogenous. Like they don't have diversity at all.
You're seeing that across the board in your patients?
Yeah, I'm seeing that a lot.
Yeah, that's really interesting.
Yeah, in patients. I just got 2 back this past week. I'm like, oh goodness, I'm seeing the same thing. I'm seeing higher levels of opportunistic bacteria.
Yeah, that's so interesting. So you're doing a stool study on your patients.
Yeah,
I think that's fantastic. I should be doing this too. I mean, I'm so focused on getting people in the door.
Well, you've got 1 or 2 things to do. You're so busy.
But I love that you're doing this. Absolutely. And so I think that the key is, how do we really get that microbiome to diversify and to improve the balance of your health supporting bacteria? And
so if I use like for, and here's one layer, let me add one layer of complexity onto this, because so many women have bowel endo. So let's just say they also have low good bacteria and a negative, opportunistic bacteria, too high levels of that. Maybe they have pathogens on top of it and they have bowel endo. What do we know? I think this is a future research question of what do lesions on the bowel, what does it do? What does it do? If it took me 36 years to finally get surgery, what were those lesions doing the entire time? How was it the reason why an individual, like I see patients who just can't shake candida, like they always have that. So that's one thing I wanted to throw in there too, because with bowel endo, it seems like it complicates it even further.
Interesting. Okay. So let's break, because that was a lot of questions at once.
Yeah, sorry.
So let's take the question of, what does the bowel endo do?
Yeah.
So what's interesting is that most of the time the bowel endo is not inside the bowel.
It's going to be like shade,
and
like
the leaky gut part is usually in the small intestine, where we don't usually see endo.
Yeah.
right?
Interesting.
So,
Yeah. Mm-hmm.
so the whole immune function and the gut, that layer, is actually more associated with the small intestine, right?
True.
So,
Yeah.
which isn't really where we're having the disease state. So, I kind of feel like they are slightly separate issues.
Okay.
And yet they go hand in hand. They're associated somehow, right?
Yeah. Yeah.
And
That
so, almost all endometriosis of the bowel is extrinsic, right? So you've got the lumen, and the disease is starting on the outside, and occasionally you're going to have cyclic bleeding that is actually from a lesion working its way all the way through, right? I mean, we see this. I've shown pictures of mucosa with endo coming out of it, but most of the time that lesion is starting on the outside, working its way to the inside, but it's impacting the nerves of the bowel, probably, and probably the thereby also the motility of the
yeah.
bowel.
Mm-hmm.
But I sometimes see this very similar symptoms in patients who have nodules on the uterosacral ligaments and not even touching the bowel, but they still have this bowel pain and dysfunction and constipation chronically and irritable bowel like symptoms. And I think that truly, like, you can have an ileus. An ileus, for those listening who don't know, is where the bowels just sort of shut down and don't work. If you have peritonitis from a ruptured appendix, for example, your bowels will just go to sleep and not function for a minute, for a day or two or five. So I believe truly that the peritoneal fluid in someone who has endometriosis is pretty much toxic
Hmm.
to the bowel. And so the bowels are always in a mild state of ileus. They're kind of in a state of dysfunction and not really functioning well, right? And this may be separate from SIBO or from this intestinal permeability picture, but it's not as though the gut is leaking into the body wall, into the body fluid, right? It's leaking into the bloodstream, creating systemic inflammation.
Mm-hmm.
And is that, and we don't know, are people with endo having leaky gut because they have taken so many NSAIDs in their lives that they've just destroyed the lining of their gut,
Yeah.
right?
Yep.
Or is there some other genetic association? We don't know the answer. But
Yeah. Would tracking, and this is more of a research question, I think, would tracking calprotectin, like as a measure of inflammation in the gut, be an indicator of whether or not versus like something like HSCRP, where we're looking at systemic inflammation versus inflammation directly in the gut? Would that be beneficial in the long
yeah,
run?
I don't know.
Yeah.
I think that following maybe CRP and inflammation markers, and then maybe a 6 month, if you're doing a very aggressive probiotic therapy, maybe try this bovine colostrum. I mean, if a calf
Yeah.
doesn't get it, it basically can't survive, right? It's so important. By the way, if you choose a product of bovine colostrum, make sure it's a product that makes it calf first so that the calves don't die.
Oh, good point.
Yeah.
Yeah.
And the products will state whether they make that important or not.
Okay.
But the tools really are avoiding the bad things. So alcohol, nonsteroidal anti-inflammatories, probably birth control, and increasing the foods that really support a healthy gut. And then that may also mean probiotics, but it's hard to know what's the good one. You have to probably choose really reputable brands. And prebiotics, so
Mm-hmm.
foods that your body has to break down in a meaningful way. And then I think maybe it's an interesting idea checking, um, 6 months later, repeating a stool study.
Yeah.
And
Yeah.
also maybe those markers of inflammation could be valuable.
Yeah. I've
I
been
mean,
tracking it.
you're way outside the box. This is not mainstream medicine at all. And yet, mainstream medicine has not done a whole lot for endo. So we know this. We have to be out
True.
of the box.
Yeah, we kind of have to be outside the box. Well, I tracked it on myself, of course. just because I had symptoms way before I had my diagnosis. So I was tracking it for a long time. And of course, being post-op, and everybody that listens to the podcast knows I had endo, so it's like no surprise that I would be tracking these things post-op. But it makes me intensely curious about the future of research in the gut microbiome for endo, because there's all these questions that we have brought up just in the context of this conversation. Like, should we? Can we? How long should we be tracking women post-op with a stool test to see if their gut microbiome diversifies? Does the endobelly, resolve? Does peristalsis and motility feel fine to them now? Is it, is
Right,
it restored?
right.
And do they have enough energy to
Yeah. So
get through their
I
day?
think the answer is this, that if someone is still having symptoms of their gut problems after reputable excision surgery, and whether they had
That's a
disc
key phrase.
resection or
Yeah.
or a low anterior resection, or
Yeah.
whatever was done to remove actual bowel disease and also adjacent disease, creating an inflammatory environment. If they aren't progressively getting better, then they probably should work with a functional provider who's going to check their stool microbiome. I think that's really reasonable, because we do also have to think about other ways which the gut is making us feel unwell.
Yep.
It may be at this point beyond endo, right?
Mm-hmm.
Yeah, I mean, you have your endo totally removed, and yet you still have this gut issue.
Mm-hmm.
What do you need to do?
Yeah. I've also seen patients, like, on a similar but separate note, like when we have ruled out, like, oh, the gut microbiome, my microbiome is looking good and digestion's looking good, but they're still having abdominal wall pain that feels similar to their endo pain before. I've actually done ultrasound imaging in the clinic and looked at fascial gliding, so like myofascial pain syndrome, and seen that they have no gliding of the internal oblique and the transverse abdominis, and everything is kind of stuck down because there's been no general visceral motility. It's like everything's still guarding. Their hip flexors are still guarding. The abdominal wall is still guarded. And maybe that's just a conscious motor pattern.
What do you do for them?
Oh goodness, I've done a number of things. Sometimes I'll send them home with something really simple, like cupping instead of massage work where we would compress the fascia. We do decompression. And so
Oh,
have them, and they can do that themselves. I can teach
right,
them in one session, and then
right.
they're off and on their way. Sometimes it's actually motor repatterning because they've used the internal oblique to stabilize everything for so long because they had no availability of the pelvic floor or the deep hip rotators to really support them. Because if they tried, it would flare everything. That they use all the superficial muscles, so the rectus and the internal oblique overfire, and then they end up with neural symptoms that they wouldn't have if their motor patterning was corrected. So I just do real-time imaging and have them breathe different ways and move different ways until all of it is freed up. And then sometimes I'll have to do visceral mobilization and scar mobilization and scar needling and things like that. But it's generally always a good outcome. They have more freedom of movement and less pain.
Oh, awesome.
Yeah. Oh my gosh, this gut microbiome conversation is so good. I think I had so many, equally curious questions when you did your presentation at Endo Summit. I was just so glad to see someone talking about the gut microbiome and endometriosis, because I think there are so many research questions that can be answered. And I'm not at an academic institution either. I'm just clinically practicing every day. So, hey, if you're listening to this and you do research in endo, I have questions. Dr. Molling, you have tons and tons of questions. I'm sure that would be wonderful research questions to pursue, because I think both of us probably do realize this. Doing research is hard work.
Yes.
It's so hard.
Half the patients I enrolled just would not do the 6-hour urine collection.
It's a
Like,
lot on the.
hello. It's like, don't
Yeah,
complain about there not being enough research if you aren't going to want to participate.
Yeah, so it's tough for the patients, and then we've got urine testing and the stool testing, all the things that aren't fun for anybody to do. But if we had some of these research questions answered, we would understand more about endo and the gut microbiome and how it would impact us. Like, imagine if we had a protocol, a few years from now of, at 6 months post-op or 3 months post-op, we do these tests, we look at the microbiome, we see whether or not there's diversity there, and get people back up on their feet even quicker. I think it's really fantastic.
I love it.
Yeah.
Yeah.
Oh my gosh. So one question, I know we got to go because we could just keep talking about this forever, but are you focusing now? I know you're just like a brilliant surgeon. So y'all, she doesn't have time to do this other research.
Thank you.
She's like saving nerves and lives over here. But how do you currently integrate like any microbiome testing, or is that down the line, like they end up with an integrative practitioner, or like if they were in my office or someone like that, in terms of microbiome testing or probiotics or other gut focused therapies, for endo?
So in Portland, we're lucky we have a naturopathic school. We have so many
That's right.
acupuncturists and
Yeah.
naturopaths and people who really want a functional approach. And some of them really think what I do is archaic and you should never be cutting this disease out, but that's okay. If they can address the functional aspect, that's wonderful.
Yeah.
Go for
Yeah.
it. So pretty much, I know some practitioners, some surgeons. There's a couple who insist that someone do a full 6 months of cleaning up their diet and so forth ahead of surgery. I don't do that. One, I want to see all that disease. I don't want any of it to be at all like suppressed. In
Minimized.
fact, I
Yeah.
don't want someone on Lupron either.
Yeah. Yeah.
And sometimes, or any GnRH analog for that reason. But sometimes disease is so extensive that nothing's going to suppress it. But anyway, I once I do the excision, when I meet for post-op, we do a few things. One, we review their video so they can see exactly what their disease was, and 90+% of the time, it's exactly where they kind of thought that it was going to be, right?
Yeah.
That's exactly where it was tethered and I couldn't move from that. And it's like, yes, exactly. It's exactly there. And you see it on your video. And it really is, it's so impactful to healing, to understand what was removed from your body and how it related to the pain that you had experienced for years. Then we always go over a plan, which is often designed, a dietary plan. It's a general form that I created that really is designed to get someone to eat more fruits and vegetables. I sound like a broken record. And really to avoid processed foods, to how they can make their own broth and so forth. Like, and what
Fantastic.
supplements I find valuable, which are usually antioxidant or anti-inflammatory supplements. I also don't think someone has to take a supplement every single day. You can take a supplement 4 days a week. It's still affecting your general system in a positive way.
Yeah.
And then resources if they need them to follow up with a functional provider. I don't really have the ability in my practice to follow through with all that. I maybe someday I'll figure out a way to do that, and I would love to. I think what I would do is for those patients who continue to have gut dysfunction 3 months after surgery, I would initiate a protocol of testing, and it might include intestinal permeability testing because that's pretty easy to do. If you're in pain and it's for your benefit, do that.
You'll do it.
Testing. You're going to collect 6 hours. A stool test, like you discussed, and a test for SIBO probably, and then adjust accordingly as best that we can. But I want to reemphasize, just as an anecdote, that there are bacteria in dysbiosis that themselves produce the enzyme that makes you reuptake your estrogen, elevating estrogen, which drives endo.
Huge.
I think that's one tiny example of this massive burden of the of bacteria within our bodies that create the functioning. And if we have an overload of dysfunctional bacteria, it
Mm-hmm.
will create disease, not just endo.
Yeah. And then add to that if they have constipation on top of it, so that, the way
Yeah, it's all
we
just
eliminate.
festering in there.
Yeah, it's just like the bathtub plug. It's like full and it's
Yes,
overflowing,
madness.
and the estrogen has to go somewhere. And endo is like rubbing its
Yeah.
hands together, like, oh yeah, we're gonna get some
Yeah,
good
we want
stuff out
some
of
more
this
estrogen.
because
That's great.
because it can't eliminate it.
Yeah, and
I think.
I mean, in balance, I'm a fan of estrogen.
Oh
At
yeah,
my
yeah.
age, I'm like, oh, give me some estrogen,
Me too.
absolutely. But right, so
Yeah,
and
yeah.
testosterone, we didn't even touch on that, but yeah.
I know. I spend a lot of time educating patients about that. So I think that's a really important point. That if you are listening, you have endo, you think you have endo, and your providers aren't talking about these topics, you might not be settling on the proper provider yet, because all of these things are essential to basically mitigating and managing, endo for the rest of your life, particularly post-op, because yes, while you can be as certain as possible that you've gotten all of the endo, we don't want to create the conditions for anything that could be there to
Right.
grow, right? And so all of these lifestyle medicine pieces and integrative medicine, because of everything that it can offer us in terms of stress management. Stress has to do with systemic inflammation. It has to do with, hormone management or not, are really critical pieces of the puzzle that kind of add up to make the whole thing come together and give you the really good outcomes that you want.
Well
All
said.
right. Yeah, Dr. Shanti Mohling, thank you so much.
Thank you,
for
Dr. Ginger Garner.
for your brilliance and your passion. And the first time I heard you talk, I just wanted to, this is a big Southern term, I just wanted to hug your neck. I was like, oh my God,
I love that.
she's doing the Lord's work out here. Oh my gosh.
Oh.
Talking about these things, because I think it's what will give us that long-term, good outcomes in addition to the brilliant surgery you're already doing. And that to me is like throw your arms around the world, holistic, truly patient-centered care that is the future of endo. So I just want to thank you for that.
Oh, thank you. Thank you for the work you're doing. And I love this functional medicine approach that you're doing with checking these labs and trying to understand why someone's still having gut dysfunction. And really you're going to the limit for your folks there. I appreciate that so much.
Oh, thanks. I
That
feel like,
inspires me.
oh, well, thank you. You know, I feel like if that helps them 10%, 20%, that's the difference between them sitting on the sofa on a weekend or walking the dog or playing with their kids outside or whatever it is that makes their life meaningful. And so to me, I just can't imagine not throwing the whole kitchen sink at it to try and make it as good as possible. So 2 questions I had left, pretty short questions actually. One is the easy one. Where can people find you? And 2 is what gives you hope in the current landscape or the future landscape of endometriosis care?
So people can find me here in Portland, and I can be found on my social media at Shanti Mohling MD. I usually post on Instagram, sometimes a little bit on Facebook, and I have a budding YouTube, which I need
All
to be
right.
working on, but there's a few things on there.
Yeah.
Anyway, I also am found at Northwest Endometriosis and Pelvic Surgery here in Portland with Dr. Nick Fogelson, and we're at www.nwendometriosis.com.
And if you haven't listened to his podcast, please go back and listen to
Speaking
that.
of his podcast, we just recorded one
Oh,
because we
yay.
are, he hasn't been doing it for a long time, and we just are resurrecting it. And our first one is going to be probably published May 1st. And that's on
Fantastic.
iTunes. I think it's Endometriosis Podcast.
Okay. Endometriosis podcast. Okay, guys, gals, all the people. I just say folks usually, and y'all.
Right. I lived in Tennessee, for 5 years. So
Oh my gosh.
I can say y'all and folks.
Y'all, you can say y'all too. Yeah.
Yeah.
All right. Well, that actually, yeah, that gives me, so much hope. You guys are resurrecting that podcast. That's fantastic. And So what gives you hope in the end?
So, I do some teaching for Intuitive, the company that makes the robot, and they reach out to me frequently as the endometriosis robot contact person when doctors want to deepen their skills and they want to have me proctor them or meet with them how they can learn to excise endo. And of course, I also am a speaker through AAGL and have taught there. But when individuals really want to learn it and they're reaching out and they are already in practice, they can't afford to go back and do a fellowship, and they really want to push their own envelope and not just burn things, and they want to excise it, they are reaching out, and there is a way in which I am able to actually um, assist in their becoming excision surgeons themselves. So that's really what we need. We really don't have very many people who devote to this.
Yeah.
So it gives me hope that there are people who want to.
Yeah, that does. It gives me hope too. And all of the patients that come in and all the comments that you see or that I see on Instagram or on YouTube or any of a number of places where like they're just like, where can I go? Or they've unfortunately already been to half a dozen people and want to know. So yeah, that gives me a lot of hope as well.
Yeah. And also hearing some of your work, that gives me hope as well. Thank you.
Ah, well,
That's
thank
great.
you. It takes a village.
It does. It does.
Yeah, it takes a village for sure. Thank you so much.
Thank you. Have a wonderful evening.
You too.
Yeah.